mammogram compared to the ultrasound. So this is an ill-defined small hypoechoic lesion, and it was biopsied and turned out to be infiltrating ductal carcinoma. And because of the disease, we have this mammogram after the ultrasound, and the whole extent shows a multiple groups of pleomorphic calcification. So the disease in the mammogram is more than depicted in ultrasound. So the breast cancer of the young is usually palpable and mostly not related to pregnancy, and yes, there is a dense breast. However, more than half of the patient shows calcification, 40% shows multifocality and centricity. Shifting to the MRI, which plays actually a very important role in the decision making, where this patient will go for nipple sparing, skin sparing, modified radical, or breast conservative surgery. It's well known that the MRI have a high sensitivity and relatively low specificity. However, the MRI is well correlated to the pathological size compared to the mammogram and ultrasound. So this is a small, ill-defined speculated mass in the mammogram. See the extent of the non-mass enhancement with related distortion in the MRI, which reaches up to a quadrant. MRI also can depict the ipsilateral and contralateral occult carcinoma, and this is a palpable, actually, right breast lesion that proved to be an infiltrating ductal carcinoma, and this is an associated contralateral sonographically occult one. Again, a locally advanced right breast one with an occult left one. This lady actually was dismissed as mastitis 4 months, and she came with this large area of distortion implicating the right upper outer quadrant, and this area of distortion correlated to the non-mass enhancement presented in the ultrasound. And because of the density and young age of the lady, she went for MRI, and here we can see the mass or non-mass that's present in the upper outer quadrant together with the multiple foci every here and there compared to the other breast. So this is a multicentric disease. This is again a young lady, and she was treated as a probably benign finding, goes for excision, and this is the residual tumor extent after biopsy in the right breast. However, there is a non-mass enhancement in the contralateral one, and her ultrasound was completely free. This non-mass couldn't be assigned by ultrasound. So we have to shift to another modality. We missed it actually, which is the mammogram. And here we can see the subtle focal asymmetry present with a microcalcification, which is wired, and it came out with infiltrating ductal carcinoma. So the MRI common presentations are again the masses, which are irregular, of shape and margin, heterogeneous, type 3, and remember that 40% may show a very well-defined lesions. And again, the second presentation in the MRI are the non-mass, and those suspicious non-mass of the young are either segmental, which represent a triangular area of enhancement, or clumped, linear clumped, that's to say small lesions in a line. But there is a dilemma actually in the diagnosis of the non-mass sometimes. That's because it may overlap with a benign finding, such as the fibrocystic disease. Here we can see the regional non-mass enhancement correlated to these small cystic lesions. So this is actually a regional non-mass enhancement of fibrocystic disease. Also, the non-mass may show a very ill-defined border, rendering the analysis of the morphology is difficult. See, this is non-mass. One may say it's a regional, and other may say it's segmental, and there is a big difference actually between the two. The regional one will be followed up, while the segmental will be biopsied. Actually, the non-mass also sometimes do not follow the criteria of malignancy of the mass. That's to say, we have this suspicious mass with marginal enhancement, ill-defined borders, and type 2 to 3 washout kinetics. However, the linear non-mass that represent DCIS actually shows a progressive one. And the last of all, the non-mass may completely be occult in the breast MRI, and this may be attributed to being low-grade DCIS, because 14% of the low-grade DCIS may be occult in an MRI. This is actually a young lady, she was 32, presented with bleeding per nipple. Ductectomy showed a DCIS, went for MRI, and here we can see the MRI bilateral symmetrical and assigned as Biroids 1. 18 months later, she came back with this horrible, sizable non-mass enhancement representing high-grade DCIS. Our next section is the neoadjuvant chemotherapy. Historically, we have the clinical examination for assessment of the neoadjuvant. However, nowadays, كلنا عدينا على السيناريو اللي الكلينيشن بيقول فيه للpatient, she is free now, and you just put the probe to see a 2-centimeter mass still there, okay? So the mammogram and ultrasound, actually ultrasound is very well, however, it can be affected with the necrosis and the edema. Also, the finding may be not complete in the ultrasound. So the MRI actually is our gold standard. And in MRI, after neoadjuvant chemotherapy, if there is a response, you have a reduction of the tumor size as early as the 4th cycle, and the cellularity and vascularity as early as the 1st to 2nd cycle. So this is a locally advanced breast cancer lady. She has a sizable mass, infiltration of the skin, and a suspicious ipsilateral node. And we can assign the ADC at the lowest one, 0.68. After 1 cycle, the ADC shifted up to 0.9. See the size, it's the same, okay? Just 1 cycle, okay? This means that this patient will respond, and this is the imaging after 4 cycles of chemotherapy. So despite of the MRI being over and under diagnosis of the residual disease, actually it shows the most accurate between all the studies. The last section is about the post-operative follow-up. We have all this scenario of the probably benign finding that was assigned as probably benign to benign finding, went for lumpectomy and came back with infiltrating ductal carcinoma with positive margin. كلنا عدينا على السيناريو ده. And these patients have only one choice for avoiding mastectomy. That's to excise all the remaining tissue, the affected remaining tissue. If this reshaving failed, she will be shifted to mastectomy. So the best time for detection of the extent of the residual disease after 1 month for resolution of the inflammation and reduction of the amount of granulation tissue. And this is actually the biopsy cavity that shows anodularity and abnormal enhancement. It shows also type 3 washout kinetics, and this is a residual disease. MRI also may show the multifocality and centricity, as we said before, because these ladies with positive margin are mostly do not have a baseline MRI, and this is actually a multicentric focus in another quadrant in the same patients. This is again a case of positive margin, and here we can see the contralateral small lesion that proved to be a synchronous carcinoma that was occult in mammogram. The last item in the MRI is the detection of the implant rupture, and we have 2 types actually of rupture: the extracapsular, which is can be depicted actually with the ultrasound, and the intracapsular rupture that's very difficult or even impossible to be detected using ultrasound as early sign. So this is an intracapsular rupture that may present as a small lesion, a small free shell, okay, as small as this one, or it can be as easy as this one, which is known as Linguini sign. So to conclude, the breast cancer of the young population commonly present with multifocality and centricity with malignant calcification that support the use of mammogram along the ultrasound. The MRI couldn't totally replace the mammogram at initial examination, so do mammogram please. The MRI may find additional disease that's occult in the ultrasound and mammogram, and it also may help to guide the clinical course and the treatment of the patient. And thank you.
Thank you, Dr. Eman, for your illustrative presentation, صراحة.
Thank you.
May I have a small question? How can we support the young female with breast cancer? She's young, the fertility. How can we support it?
Support means, I think, 3 items: the management, that psychological aspect, and as you said,
very important, the psychological
yes,
aspect.
The fertility preservation also. Yeah. And nowadays, I think they postpone the chemotherapy for a while until they preserve the follicles or the ovarian tissue. They can excise the ovary and reimplant, or they can move the ovary or preserve follicles and then use it later on. They have to excite the ovaries for a while until they extract the follicles.
Do they need to have a genetic counseling, for example, or something like that?
For the young, for all cases?
Not all cases, but they need one.
Yes, there are specific items to be fulfilled for genetic counseling. For example, more than 2 cases per family, young patient in family, a male breast, and so on. Okay, if there is a colonic cancer, ovarian cancer associated, bilateral breast cancer, all of these cases are assigned for laboratory genetic counseling.
Okay, thank you so much. Thank you.
Thank you.
I have a question here برضو أو comment يعني بمعنى أصح. As long as we are talking about the breast cancer in young women, many to refer to the المبادرة الرئاسية لصحة المرأة, because of the increasing diagnosis of early breast cancer in young women. احنا ابتدينا نعمل starting of screening for the women from the age of 18 سنة. بنعمل لهم self awareness, how to breast self examine, والnature ونوعيهم, وبناخد questionnaire على if there are any risk factors. وطبعا بتبقى subjected later on لو حصل أي شكوى complaint بنعمل clinical examination و refer her for ultrasound if it is younger than 35. If it is 35 onwards ممكن نعمل الماموجرام والultrasound for diagnosis. This is number 1. وده which I urge every one of you in your own facility where you work to emphasize the importance of early detection, because usually those cancers that attack young women are of the aggressive subtypes, as you mentioned, the HER2 positive and the triple negative. Number 2, which is very important during the early diagnosis and neoadjuvant therapy, it's very important to put a clip usually in the second session of neoadjuvant therapy, because these tumors respond very, very well to the neoadjuvant therapy, so that to the extent that they might disappear later on, and it will be very difficult for you to localize the original tumor. So very important to put a clip, especially in the cases of the HER2 positive and the triple negative tumor. These are 2 points that I wanted just to share with you and to evaluate their importance in your daily work. Okay.
Thank you دكتور أشرف. أنا عندي بقى سؤال وطلب لحضرتك.
اتفضلي.
أول حاجة السؤال، هل في incidence لليونج age breast cancer طلع دلوقتي بعد السنين دي ما عدت في السكرينينج من 2019؟
Yes, of course. يعني اللي عايز أقوله إن إحنا عملنا، يعني أنت قلتي 20% which is
في 2014
اللي إحنا وصلنا له إن it's about 12% for those less than 35, and from the 35 to 40 الجروب ده بالذات ده وصلنا في تقريبا 10%.
اوكي.
فانت عندك 10 و12 يعني 22%, which is more or less the same. احنا الانسيدنس ما بنقدرش، هو يعني هيفضل الانسيدنس، ما احنا ما بنلعبش فيه، انما المهم هو الايرلي ديتكشن، لان الكانسر في اليونج ايج is rapidly growing and very aggressive, and the most important point is to early detection which is our role. ولازم نعمل كل ما في وسعنا عشان نعمل awareness في الكوميونتي على الامبورتنس of regular screening، وهو موجود دلوقتي في كل مستشفيات مصر دلوقتي بنعمل السكريننج.
الطلب بقى. احنا يعني عندنا كل حاجه نيرلي في مصر، يعني في شويه حاجات ديفكتيف، من ضمنها في السكريننج بروجرام ان يبقى عندنا بروجرام فور اسسمنت اوف ذا ريسك.
الكويستشنير زي ما قلت في الاول ان ده بيتعمل كويستشنير، وده بيبقى فيه الاسسمنت اوف ذا ريسك اكوردنج، وفي فورمولا معينه بتقدري ترجعي لها وموجوده في يعني جاست جوجل ات وهتلاقي الفورمولا بتاع ريسك اسسمنت، وده بنعمله في الكويستشنير بحيث اللي هم دوز ات هاير ريسك بنخلي لهم يبقوا ليهم very regular visits، ونبقى حاطين عينينا عليهم دايما كده.
Thank you, دكتور.
Now I have to present دكتورة